Thank you so much for joining us in this movie. I hope you really enjoyed the movie. But actually, the big thanks goes to the operator who did this very interesting cases, and let me just enumerate them according to alphabetical order. Dr. Ahmad Khalil, he is from Hospital Essen Duisburg, Germany. Thank you so much. Dr. Dr. Sulaiman Gunay, Ataturk Training and Research Hospital, Department of Gastroenterology, Izmir, Turkey. Dr. Alexander Schlatterman from Thomas Jefferson University Hospital, Philadelphia, USA. And Dr. Chu Kwang, MD, so it's from Dr. Chu from Taiwan, so the Fellowship of Gastroenterology, National Taiwan University Hospital. Thank you so much, and I hope that you really listen to the voice. I hope the voice is really clear at your sessions right now. And if there is only one thing I would really get learned from this videos and the conclusion, it's only one thing, it would be the decision making. How would you decide what will you do inside the complication? And to reach this point of information for the decision making, I believe that you should have the knowledge and also the expert needed to reach the correct decision in the very short time. Let me please open the floor of discussion right now, and I will go with first our guest, Dr. Ahmed Saeed from United States. Please, Dr. Ahmed, do you hear me very well? Thank you so much. Thank you for joining us today. And I will leave it to you. So please, if you are into any discussion, any questions with the operators, I believe they are with us right now. So would you like to pick a video, or do you want me to pick one?
Outside and put the clip on, I would not limit the size or the the opening that I created in the tunnel, because when you place the clip on top, the lumen of the tunnel would be limited and you'll have to dissect more. I would probably just go in and dissect deeper, make the tunnel longer, and then come back and place the clip on. So that's my comment on the first video. I'll probably let the other panelists also participate. I have some comments about the other videos too.
So would you please just let me pass the talk to Dr. Alexander? So Dr. Alexander Chelsterman. I don't think he would be able to join us today. So back to Dr. Ahmed, please. Would you please continue for the other cases?
Yeah, so I saw the second case with Dr. Goulier rectal ESD. So during the dissection, you can definitely see the injury to the muscle layer or the exposure of the perirectal fat. So that's in the rectal space. I feel that this is something that can be, so you can continue the dissection, you can finish the ESD and then focus on the closure. I typically don't worry as much if I have rectal fat exposure during ESD, and actually in some cases with some of the tumors involving the muscle, we do strip off the muscle and expose the fat and continue the ESD, finish the resection, and then focus on the closure. That's not the case in any area in other areas of the colon. Once you're into the peritoneum, you definitely want to stop, finish the resection as fast, switch to like hybrid ESD, and make sure that there's no liquid on the side of the perforation, so you limit the spillage of colonic content into the peritoneum. But in the rectum, the perirectal fat typically just sits right on top of the rectum, and that limits the amount of spillage that gets out of the rectum into the perirectal fat. The only difference, what I would do different is I would finish the dissection with ESD. I wouldn't switch to the snare earlier. In this case, probably it was safe and the lesion did not look like it's a cancer. But in some cases, if you don't end up with an in-block resection, you don't get the full benefit of an ESD. So I would do the closure at the end of the ESD. I wouldn't have switched to the snare, but the closure was done perfectly with the clips. It was complete, secure closure. So that was impressive.
Dr. Suleiman Ganai?
Yes, I am here. I am hearing.
So let me tell you exactly what was the question of Dr. Ahmed. He said that such lesions in the rectum, I usually don't get panic a lot if I see the rectal fat. I will continue dissecting the submucosa, and then after finishing all the procedure, then I will go to the closure site. Do you agree with this?
Yes, exactly. I agree with him because rectum area safer than other localization, especially first haustura, safer than upper rectum or sigmoid or other places. Don't panic with the perforation in the rectum, especially in the big part of the after the linear dentite. Yes, don't panic.
But we saw you that you just raised the lesion, did EMR, hybrid ESD, and then you went back to the closure. Why didn't you just continue to dissect the submucosa?
No, after when I saw the perforation, I stopped the endoscopic submucosal dissection, and I take a snare, and I am focused on the for closure.
Is there any question from the floor or chairpersons for Dr. Suleiman according to the ESD case and the open poem case? Dr. Wael? You have one question from the chairperson, Dr. Wael Arif, the consultant and professor of gastroenterology in Cairo University.
Okay.
Professor Suleiman, it was really nice cases, but I think the open point, you wouldn't be afraid of micro defects in the muscle layer, through the muscle layer, when you do the muscle incision open like this?
You want to ask me for the muscle injury. I did only circular myotomy. I preserve
Longitudinal?
longitudinal longitudinal muscle. I preserve longitudinal muscle, and I did cut only circular muscle.
This is why you used the scissors?
Clutcher cutter?
The cutter you used instead of...
I use cutter. Some position is easy for the cutting muscle, and I use some area, I use dual knife, but some for position, easy position, cutting the muscle, circular muscle.
And regarding the results of the poem, when you just cut the circular muscle and leave the longitudinal muscle, the results of the poem after this patient?
The question is about the result of the end result after the open poem.
Yes, safely the patient is good. After 3 or 4 days, take liquid food and no problem. And also I speak with my patient, also is good, no problem. In Japan, Professor Liu from China. He has I think 19 cases open poem. He reported open poem first author in the world. Okay.
Yeah, thank you. Thank you so much, Dr. Suleiman, for joining us. And back, please, Dr. Chu Kwang. And I would go with Dr. Any question for Dr. Chu? For the 2 cases, one of them with the overstep after making intended perforation, and the other one with the bleeding that he did around circular mucosal EMR, endoscopic mucosal resection, just to clear the field to see the bleeder. Any questions from chairpersons? Okay. Dr. Chu, please, I would like to ask you, especially for the second case with the overstitch, when you did, if you didn't have the chance that you have in your institute, the Apollo overstitch, would you go with the same approach, or what will be your approach?
If I don't have overstitch, maybe we can try purse string closure. We use clip and endo loop to close the wounds. However, we must inform the patient that it's not strong, because without overstitch system, the closure is not whole there. We can only approach the mucosal, so the break of the wound is possible. But with overstitch, we do whole layer approximation. We suture the muscle, so the suture is so strong. So it's totally different. I still would do it, but I will inform the patient we have the risk of delayed perforation.
That's right. But
Can I ask a can I ask a question, Dr. Chu? Hi, Dr.
Yes.
Sharif, Dr. Rathod here.
Hi.
How are you doing, Dr. Rathod?
Yes, a question for Dr. Chu. If I'm not mistaken, the lesion was 5 centimeter, what you resected, the gist.
No. It's around 3 centimeter, not that big. Yeah.
Okay,
Yeah.
okay.
Yeah.
So you were able to retrieve it easily after resection through the esophagus, 3 centimeter?
The tumor, the gist is around maybe 2 to 3 centimeter. Yeah.
Ah.
It will larger when there is a mucosa there, but the core is only 2 to centimeter. Yes.
So did you take it out fully for the histopathology?
Yes, sure. It's complete. Yeah. With the mucosa, with the muscle there, with the serosa. Yeah.
So what is your cutoff line of a gastric lesion? Suppose this is a 5 centimeter lesion. How would you take it out?
5 centimeter lesion, I have maybe 3 or 4 cases, but it's not actually 5 centimeter. It's a oval one, you know. It's long in 5 centimeter, but its diameter maybe 3 centimeters, so it's not that hard to pull it out. But it's if it's 5.1, maybe it's a little bit harder to pull it out, but it's still possible. Yeah.
Thank you.
I do have a question for
Rathod,
Dr.
please.
Chu.
I will leave the case of Dr. Ahmad Khalil, the ERCP, the bleeding ERCP, and the metallic stent migration to you. So please, I know that you will have so many questions to Dr. Ahmad to ask him. So yes, please.
Okay, so Dr. Sharif, I am thankful for this kind invitation.
My pleasure.
Meeting all the colleagues online and you after a long time. Thank you very much. Wonderfully conducted the cinema. First of all, I would like, please don't take this as a fault-finding mission from my side.
Right.
But I hope that this meeting is for education for upcoming aspiring endoscopists, gastroenterologists, those who are available or those who are attending it, as well as those who are online attending it.
Yes.
So first thing I would like to say that the whole ERCP case, if a 8 millimeter stone, it was too much of a treatment for an 8 millimeter stone. First of all, don't feel bad, Dr. Khalil. I'm not here to find fault with anybody, but this is for the education of the youngsters.
That's correct.
I do not know why there was no sincere effort made to look for the site of the bleeding. That is number one. Where was there any effort made to give a balloon tamponade before you decided for putting a stent with a stone extraction balloon at the ampulla or in the bile duct?
Right.
And if you remember, if you look at the stent related complication, you could have led to a massive perforation in trying to take out those stents with a balloon.
That's right.
So one complication can actually lead to the second and the third, and that would have been a series like a domino effect. And therefore, I feel that I want to convey two important messages to youngsters here. When I got trained in ERCP, that was in early 90s, I would say, there was still diagnostic ERCP. But now we have only therapeutic ERCP. And therefore, either you do ERCP with proper training or you don't do ERCP. There is no such thing that I can do ERCP.
Right.
Because then you are going to expose your patients to grave complications. So the steps which were shown, finally patient was extremely lucky to get away without a perforation or any other major complication. But the moral of the story for the youngsters is very clear. There is no substitute to proper training under a mentor with proper techniques.
Okay,
for
I got
safety.
your point. Yes, thank you so much, Dr. Rathod.
So this is what message
Yes.
I would like to convey, as we have significant experience in this field.
Yes.
And I felt was on the gas when he placed the second metal stent. So if you look at the cost of this procedure,
That's
this
correct.
cost of the procedure for 8 millimeter stone is more than a major exploratory laparotomy.
Oh, yes,
So
I
this
agree with
is
that.
something which, so I don't feel bad, Dr. Khalil. I'm not here for fault finding mission, but I'm going to convey this to the youngsters with this spirit that things could have been done much more simply. And if you be very careful, then we can avoid the first complication, and you should.
Yes, that's right. Let
My
me pass the question to
message
Dr. Khalil, and I can see a smile on his face. So please,
to the audience.
I believe
Thank
Dr.
you.
Khalil, you are going to answer the question in your query.
Yes, me. Yeah.
Yes, Dr.
All right.
Khalil.
So on just going back a case,
Okay.
if you don't mind going back to the case of the gist resection, if you can hear me.
Actually, right now we have Dr. Khalil. Just he was going to comment about the ERCP case. So excuse me, please, Dr. Ahmed.
Okay.
Yeah, I'm sorry.
First of
That's
all,
fine.
I would like to thank Dr. Sharif Al-Bahiri and Dr. Muhammad Amir for this kind invitation. The comment from the dear colleague is a little bit exaggerated, but it's kind of when we see endoscopic procedure in just a cinema, it's a little bit very easy to make such comments, but I've already performed more than 3,000 ERCPs, and you know well, in an ERCP scenario, it's don't go this way, as the dear colleague had said. I have already, in this special case, was our fellow had make his trial to access the papilla. We don't sedate in general anesthesia, we sedate only with propofol. That was a critical ill patient. It was further access. I have decided to perform much further intervention to help the patient in sepsis in a very critical ill situation. So I performed fasciculotomy and sphincteroplasty and removed the stones and in very quick method. I have seen the bleeding. I tried to treat this bleeding, but this the video was a little bit very long, so we have to make it very short. So you didn't see anything in the video that was really should be short. The patient has moved during stent placement. That's why the stent migrated. It has propofol and moved. During the stent placement, the nurse panicked. I have to help this patient. I have done this stent and stent procedure, and I have to end the procedure. After 2,000 milligram propofol, the patient unstable. That's such scenarios. It's not shown in such film. You have to keep in mind we are dealing with people, not with machines. So when we do 1,000, 2,000 ERCPs, 3,000 ERCPs, 10,000 ERCPs, we have to bear in mind that we are dealing with human beings, not with machines. So I have to help this patient as quickly as possible. So I have done what we should do in such scenarios. So I do stent and stent. When stent migrated, I tried to let this stent out, but it couldn't be possible, and I have to end the procedure. So I have done the other stent. In the other setting was a little bit difficult. In 2 hours, I have to remove this stent. It was very difficult, but I have actually succeeded to remove this stent.
Yes.
Without the need for operation.
Thank you so much, Dr. Ahmed. Definitely, we cannot judge all the procedure just from this video. Actually, we got short on time. Right now, again, I would like to just thank all our experts that are joining us through Zoom, Dr. Viptori Rathod, Dr. Ahmed from USA, and Dr. Chu, Dr. Sulaiman Gunai. Thank you so much again in your review. Thank you for all the chairpersons. Thank you for the audience for attending such a movie, and thank you so much for all the board. I appreciate it.